Welcome back to this edition of Ethnic Health America. My guest is Dr. Mark Smith. Dr. Smith is the director of the California Healthcare Foundation, and I think an expert in what the dynamics of what's happening in healthcare in the country, and I thank you for taking the time to join us.
Nice to be here.
Now, the last time we talked, the whole healthcare reform issue was evolving.
Right.
What's evolved?
Well, since the last time we talked about this, two big things have been involved. One is it was after a big fight, it was passed, and then the election happened, and a lot of people who got elected in the last election promised to undo it. So I guess the question is, where are we now? The law was passed. Some of the provisions of the law went into effect in 2010. More will go into effect in 2011. A lot of the big changes that will cover a lot more people, though, don't really take effect until 2014. But there are some things that your viewers might want to know. So, for instance, if you've been unable to get health insurance because you had an illness or a disease that meant an insurance company said, we're not going to cover you, there now is everywhere in the country a high-risk pool, including in California, where you can buy insurance even if you can't be underwritten. Another big change. Now, under the law, if you have a kid who doesn't have insurance through their own employment or otherwise, they can be carried on their parents' health insurance until they're 26. So that's another big change. A lot of the changes that will happen, though, with insurance markets and subsidies and expansion of Medicaid won't happen until 2014. Of course, there are some in the Congress who'd like to repeal it and undo it. We'll have to see if that happens or not.
But I think there's still a lot of confusion because just on the back of, you see the healthcare reform on one page, you see that the insurance companies are increasing deductibles, raising rates. I think most people who, when they thought about healthcare reform, thought that process would stop.
I think they did, and frankly, they were probably justified to do so because a lot of the politicians who were talking about healthcare reform sold it as saying this is going to control premiums. I think most of us who know something about healthcare think that the reform bill did a lot to increase coverage, but the things that it did to reduce the cost of care, if they're effective, they'll be perhaps many, many years before they're effective. And so I think you're right, we've got this paradox that for the next year or two or three, maybe longer, the premiums that people face will often actually be going up rather than down. Again, some of this will change in 2014, and one of the things that happens in 2011 is that state insurance departments will have more authority to review rate increases and render some judgment about whether they'll be allowed or not.
That's already happened in a couple of states. I mean, I read in some articles where some were certainly here in California where Blue Cross wanted to go up to 39%.
Right.
And so, but I still think that most people think, well, healthcare reform, I'm going to look at my paycheck and I'm going to look at my insurance plan and it's going to cost me less. And I don't sense that that's going to be an immediate impact.
Well, I think that's right. I think that's part of the political problem that the proponents of healthcare reform have. To the extent that you sold it as you're going to see your bill go down, then the bill goes up, people are saying what's happening. I think it's important to remember we get an insurance premium in the mail, or as an employer, you get an insurance premium for your employees. And we tend to blame the person who sent us the bill, that is to say the insurance company. But as much as you may want to yell and scream about insurance companies, and I know it's easy to hate insurance companies, the reason that health insurance costs so much is mainly because health care costs so much. It's a little like blaming the waiter when you get the bill at the end of the meal. Well, yeah, the waiter's the one giving you the bill, but the cost of the meal was in part what you ordered and in part what the restaurant served and what went on the menu and back in the kitchen. And so often we want to kind of control the last bill we see, but the reality is the things that insurance pays for, the x-rays and the surgery and the doctor's visits and the drugs and all the things that make up health care that insurance is covering, that's really what it is that costs too much.
That we don't have the best healthcare system in the world. I mean, we're 19th or 20th and as much as 30th in some of the key measures of healthcare. Are people getting what they pay for?
Well, in some ways they are, in some ways they aren't. It's a little complicated. You know, some people say, oh, it's the best healthcare system in the world. It's clear that there are many other countries, including countries that spend a lot less on healthcare than we do, that have much better systems of primary care. When your average routine need to go to the doctor stuff is looked after much more quickly, much more appropriately, much more conservatively. It's clear there are many other countries that have just as good access to all sorts of drugs and devices. In fact, sometimes better access to new drugs and devices than we do. But it's also clear if you're really bad sick anywhere in the world, you probably want to come here. You don't want to go to France. You don't want to go to England. It's part of the reason that Arab sheiks and emirs and wealthy people all over the world come to this country when they got something really bad. So it is true that at the high end, when it's really complicated and expensive, we probably do that better than any place in the world. The unfortunate thing, though, is that for kids with asthma or for women with hypertension, we don't do a very good job of that. So it's kind of a mixed bag.
Well, I think that the other countries, it's when you start to talk about the way in which we select to identify ourselves in medicine institutions, particularly, always everybody wants to look at be a tertiary care hospital, for instance. Well, other countries are starting to figure that out, aren't they? I mean, they're starting to put together these magnificent tertiary care hospitals with no hospitals for the other.
Well, that's right. And in fact, in Singapore, in India, in a number of places in South America, it's now possible if you want your hip replaced or if you want even a heart operation. I'm not talking about cosmetic surgery now. I'm talking about difficult, life-saving, complicated stuff. It's possible for you to go to that country and be operated on by a first-class team, including physicians who were probably trained in the United States, and get away with a bill that's 1/10 or 1/20th of what it is here. So, but that really shouldn't surprise us. Given kind of globalization, it used to be possible for one country to have all the knowledge and all the expertise. But as the auto industry has learned in the last 40 years, no reason why Japanese people can't make great cars and no reason why Indians can't do great surgery. So in fact, I think most Americans will always get most of their care here. But the fact that there is growing expertise and excellence in other parts of the world, including places where it's a lot cheaper, I think will put pressure on people in the United States to figure out how to do it less expensively.
In terms of context, I think there are a lot of people who feel that from a healthcare perspective that all we need is just a little bit more small business stimulation, bring all these jobs back. But just like in other areas of employment, in the healthcare area, the same. The three dynamics, I think, seem to be affecting our situation here as much as anything else. One is technology. I mean, quite clearly technology now is more expensive, eliminates the need for a lot of the human capital that used to go into healthcare. The second is globalization, just like you talked about. I mean, when I was in India, there's premier hospital, they had heart surgery, $4,800 a year, the whole deal, and that's going to affect us here in this country. And the third is politics. Now, I've seen some interesting statistics recently. One is that most Americans don't want the health care bill reversed. Secondly, that most of the judicial decisions justifying the health care bill have gone in favor of the health care bill. So what do you think the impact of a newly formulated Congress is going to have on the health care reform bill?
Well, it's too soon to tell, but I don't think we should expect that it will be reversed or repealed or overridden. A lot of it is in place, it's moving forward, and while I don't have a crystal ball, the fact of the matter is a lot of the delivery system changes that you're going to see, hospitals will get bigger and will consolidate. Hospitals and doctors will start to talk with each other more about how to work together rather than being separate entities. Those things were underway before the bill got passed. The bill is going to accelerate them. So from my standpoint, I think we should expect from everything I know that much of what was in the bill won't be implemented exactly as it was passed. There are things in the bill that don't take effect until 2018. So stop and think about it like this. What were you doing in 2002? Where were you? What did the world look like? That was as long ago in the past as some of the stuff in the bill is in the future. So things will undoubtedly change. But my own view at this point is it's likely that most of the bill will be implemented. There'll undoubtedly be things that will be changed. We'll learn that some things they got wrong. But I think the basic motion is set because the basic problem that the bill was designed to address, that health care was increasingly unaffordable for people and they needed coverage, and that the system was organized in such a way that you couldn't get your hands around it to make it more affordable, those problems aren't going to go away, and politics is not going to change that.
Our discussion was with Dr. Mark Smith. He is the CEO of the California Healthcare Foundation. We're talking about healthcare and healthcare reform. When we come back, we'll start to talk about what a system we have and what the system ought to look like. We'll be right back after this break. Welcome back to Ethnic Health America. Our discussion with Dr. Mark Smith, the CEO of the California Healthcare Foundation, continues. Dr. Smith, we know what we have and we know what we've had. What should we have in terms of a good healthcare system?
First of all, I think we need a system that's far more responsive to and convenient for patients. I think we have to admit, both of us are physicians. In lots of ways, the system is set up for the convenience of the providers rather than the convenience of the patients. You and I are both old enough to remember if you wanted to have a big weekend, you had to be at the bank by 3 o'clock on Friday afternoon because that's the only way you got cash. If you think about it, we don't do anything the way we did 20 years ago. We don't shop the way we did 20 years ago. We don't make airline reservations. We don't get our news or information. We don't bank, don't communicate with our friends. But the only thing we do pretty much the way we did 20 years ago is healthcare. And so the technology in healthcare moves all the time. We got new machines, we got new gadgets, we got gizmos and drugs. But the basic business model of healthcare, the hierarchy between providers and patients, and the basic unresponsiveness of the system looks pretty much the way it did when you and I were in medical school. That's going to have to change. So I think in the next 10 to 15 years, you're going to see an explosion in the capacity of people to do for themselves things that used to take a professional to do. Just like in every other aspect of our lives, whether it's doing research or making travel plans, we now do, with the aid of technology, all sorts of things that would have been unthinkable 15 years ago. I think that's part of the way that we get this system under control cost-wise, is that we allow people to do for themselves things that they can.
You know, I think that certainly would appear to be right. But I have a sense that when people start talking about their health, it's very difficult for them to either do things that are proactive or to do things that involve compliance or that are reactive. And even as I start to look at the other options, what you're really talking about is a patient-centered healthcare system. I think that people can go online and get this and get that. But, you know, at the end of the day, when you tell someone that they're sick or they think they are, it still seems that you need that individual in the mix in order for that to flow nicely. Now, the thing that I think really kind of cost us in that patient-centered healthcare system is compliance. I mean, I don't know, when we talk about ways in which we look at the system, in the studies, be they study of social determinants or medical things, they throw out the non-compliant patients, send them back to me, send me the data on compliant patients, and ask me to utilize it.
Right.
And so what kind of research model are we using in this country that would allow this patient-centered healthcare system to work?
First of all, I'll give you an example. If you think about the number of times that we have patients moving back and forth to the doctor, rather than having the information move back and forth to the patient. When's the last time you went someplace to get a piece of information?
It's been months.
Right. And yet, a lot of the visits that our patients make to us are because we have a reimbursement system that pays us when they come see us, as opposed to emailing them the information or communicating in other ways. Second, if I were king, I would say there's an urgent need for us to figure out how we could administer drugs once a month rather than twice a day. That would certainly help compliance a lot. And so I think there is an agenda that says we've got to make this easier for people. There's also an agenda, I think, that goes way beyond healthcare, because a lot of the healthcare costs that we have now are due to conditions that have really little to do with healthcare itself. They're obesity, they're diabetes, and that has to do with foreign policy and zoning policy and lots of other things. So I think there is an agenda for the nation to think about prevention as opposed to loading more and more costs up on a healthcare system to fix stuff that we've broken.
You make a really good point. I just think, what responsibility has the patient for the cost of healthcare, for outcomes, and do you think people are willing to accept that responsibility?
I think they are often. My own sense is that patients are willing to accept a lot more responsibility than the system usually gives them, in part because we give them few options. We say, you come to my place on my schedule, on my terms. So I think because we can't afford that system anymore, that's clear. I think there will be opportunities for patients to frankly have to learn how to do some new things on their own, but the payoff will be that things will be less expensive and more convenient, and that's the system that I see evolving in the future.
Well, Dr. Smith, certainly always your insights tend to be disturbingly correct, and I think that much of what you said is true. I still think, having seen some technology and implemented some, that people still need a lot of hand-holding in the healthcare system, and that costs the system a lot of money.
But you know what? A lot of the hand-holding they need doesn't have to be doctors, and it doesn't even have to be nurses. And so that's another place where we can make this better.
Another shot at my self-esteem. All right, well, thank you very much. We'll be right back after this break.